I'm here for your treatment. I saw you updated your Facebook status as short of breath. That seems accurate, yeah. You're not going to work for me? There we go. All right, so today we're going to just talk about doing a small volume nebulizer treatment and talk a little bit about meter dose inhalers. Thursday, I'm not going to hold off doing anything today because for one, half of you aren't here, and for two, I like having Amber available so we can supervise better. But we'll talk about doing a therapy. When we actually do the performance evaluation, you'll be doing it on a mannequin or on one of us, one of the two, but not on each other. But you'll want to practice doing this. We know about documentation. This is an example of the SOAP-EUR format. I think I've heard of at least the SOAP format because I know you're using them in your case studies. But again, the implementation, documenting that, and then evaluating the results, and revising any care plan. So this is a scenario. Mr. Sullivan's a 55-year-old man into the ER. He has a documented history of bronchitis. We're assuming it's a chronic bronchitis, and also has some asthmatic components. The physician requested that we assess the patient and make recommendations for therapy. So first thing again we want to do is go back to that primary and scene survey. Is the scene survey safe? He's in the ER, so hopefully that should not be an issue, but you always want to take that into account. And then looking at our primary survey, our critical life functions, we notice that he's tachypnic, he's tachycardic, obvious diaphoresis, audible wheezing, and excessive use of accessory muscles. So again, looking at our problems, we definitely have some problems with ventilation, probably some problems with oxygenation also secondary to that. And it really is, I mean, his circulations, he's tachycardic, so he is responding appropriately, but we need to do a little more investigation of that and the perfusion. Looking back at the patient's chart, want to make sure that we have our written order. We have a history so that we can go back and see if there's any kind of indices in the medical record as far as how severe this is. Looking at his code status is always nice, so that when we walk in the room, we're not finding that he's a no code and we're there, supposed to be doing something to him. Looking at any allergies he may have. Is there anything that relates as far as infection control, as far as transmission-based precautions? Doesn't appear to be, but always want to take that into account. Any kind of lab work that you may have, and any prior treatments that might have had some adverse effects, or if there's any other medications that he may be on that may come in conflict with what we're going to do. Then getting back to our standard process of going in. Hi, I'm Rick from Respiratory Therapy. I'm here to administer a breathing treatment for you. Again, identifying the proper patient and explaining why we're there, what the length is, won't hurt, and what do they need to do. And then looking at some other things as far as the interview, what kind of some of the subjective things, if they're expressing anything as far as dyspnea, if they have any, if they have the presence of a cough, and if it is it productive, any presence of hemoptysis. Looking at things also that rule out other aspects as far as fever and night sweats are a couple of key things. And then looking at have you had this therapy before and how did you feel that it benefited you. Other bedside assessments that we might want to do prior to therapy, especially if I'm looking at using a sympathomimetic. You want to venture a guess? Okay, how about a peak flow or an FEV1? Something to assess efficacy of the therapy. Go ahead then and do our process of washing our hands, putting any personal protective equipment, at least gloves. Make sure the patient's in the proper position, and for a breathing treatment, you want them to be in either a high Fowler's or at least a semi-Fowler's so they could take nice, easy, deep breaths. Looking at, from an objective standpoint and a subjective standpoint, what are their baseline values, things like level of consciousness, their color, not always blood pressure, not always temp, but certainly breath sounds and heart rate and heart rhythm should be done. Respiratory rate, respiratory pattern, and also if there's anything that as they're speaking in short 3-word sentences, that's indicative of some severe respiratory distress. And we mentioned at least getting a peak flow, perhaps pulse oximetry reading, and then not necessarily getting a blood gas, but if there's any of that data available to us. So what do you think we should recommend for this patient? Well, how about an aerosolized bronchodilator? He's got signs of respiratory distress. If that doesn't seem to work, we can certainly look at using intravenous steroids, and then also perhaps some oxygen therapy. Specific medications, of course, albuterol, right? Perfect for everything. Normal dose, you know, or if you don't know, you probably should know before this morning's exam. 2.5 milligrams. We usually use 3 milliliters of normal saline as the diluent. Do that every 20 minutes times 3. It's basically what we call a back-to-back-to-back to see if there's relief. Alternatively, you can look at doing 4 puffs of albuterol via MDI using a holding chamber, and again can actually increase that 4 puffs up to 12 if not seeing a relief. If that all doesn't work, then we could perhaps look at a continuous bronchodilator therapy, 15 milligrams per hour, and you guys remember how to go ahead and set that up to be able to deliver. I think that was a test question last time, wasn't it? Doing a continuous therapy. This is what your nebulizer hump. Oh God, no, forget it. Egan does have an algorithm for bronchodilator therapy. This is for children over 5, so because we do have some things that under 5 wouldn't be able to accomplish. But you can see where the green arrow is the SVN, 2.5 milligrams every 20 minutes times 3, and then can gradually go from there as far as how the degree to which they improve. Our supplies that we're going to need, well, we're going to need the nebulizer itself and its associated tubing and mouthpiece. We usually have a setup bag so we can leave it at the bedside, kind of like what you guys have in your cubbies. Always want to have the stuff that we're going to be needing: stethoscope, watch with a second hand to take a pulse and a respiratory rate, some sort of paperwork, although now again with the EMR it's prompted through the computer. We need some sort of a gas source, either an air or oxygen flow meter in the hospital or in the home environment. We would use a compressor. Looking at an oximetry we talked about, peak flow we talked about. He doesn't like your order. He says, I want 5 milligrams. Okay, well, explain that that's twice the normal dose and not the recommended frequency. So you want to go ahead and recommend using the standard dose, and if need be, giving that standard dose more frequently or in subsequent numbers rather than giving a big dose initially because of the side effects. So what do you do if you come across an improper order? And Lori probably went through this, but just let me briefly go through it again. As a student, you're going to contact your preceptor. Don't take anybody on at that point. Contact a physician. If it's an intern, talk to them. If you don't get response from them, you go up the chain. Every intern has a resident or a senior resident that they report to. Ultimately, there's the attending physician, and then there's but there's also as a component our medical director as well as the chief of staff. So there's always somebody that is higher up that we can take the problem to. And then informing the patient and nurse as far as why there's a delay. If you're an employee, you're now a registered therapist, if you're having problems, you can contact the supervisor. You could certainly enlist the assistance of the pharmacy. And lastly, just here, doc, here's the medication, here's the nebulizer, you go give the treatment, because this is outside of a safe process. And long about, when you start getting to that point, they start second-guessing themselves. They go, maybe I'm doing something wrong here. Prior to therapy, we want to make sure we have our gas source that's functioning. We're going to keep the nebulizer itself in a clean fashion so that we're not contaminating it, especially the mouthpiece. Make sure the medication is the proper medication, proper dose, that it's not expired. Go ahead and insert the saline and the medication into the nebulizer cup and set our flow to somewhere between 5 to 8, whether we're using a compressor or we're using a flow meter. Instruct the patient that we want them to breathe through their mouth. We want their breath to be slow and deep, and occasionally have a breath hold. Longer they can hold the breath, as we know, the better the deposition is. If they're in distress or having personal breathing, you can use a mask as an alternative. Try encouraging them to breathe through their mouth, not through their nose. And at this point in time, if we're noticing that they're using accessory muscles, we can focus on them breathing using diaphragmatic breathing. Monitor the patient before and after the therapy, certainly using peak flow, definitely during a pulse. You want to take a pulse before you start, you want to take a pulse during the therapy, and you want to take a pulse after the therapy is done. That, as well as breath sounds and respiratory rates and assessing the work of breathing. So this is a continuous process. We do our initial assessment, and we want to monitor a few minutes into the therapy, and you want to monitor at the end to see if there's any adverse problems happening. Great time while we're there to teach the patient. You'd be amazed how many, well, maybe you wouldn't be, how many patients have no idea what the medication they're taking actually does, or what the disease they have actually, what's actually going on with them. Finding out what their daily activities are, as far as, do they wake up every morning and have a cough with sputum production? If they're using peak flows, identifying if they've been, if they've established a personal best, and do they know what the red, yellow, and green means of their traffic light? Also cleaning of stuff, especially in the homes, a little bit different, obviously. And then if they're still smoking, trying to get them into that. So the initial aerosol therapy has been started. Patient's been administered for 5 minutes. Monitoring indicates that the pulse rate went from 112 to 140, and audible wheezing appears to be improving. I'm guessing that that means that there's less audible wheezing than when I started. I don't know how you have a negative thing improve, but that's the general essence of what I'm supposed to do. What do you think about that situation? Are you happy with a heart rate of 120?
Not go over 20.
You should not go over 20 beats. Yeah, so I mean, it's elevated a little bit, but it's not something that I'm going to get my shorts in a knot just having that small increase of 8 beats per minute. What's more clinically significant is that the wheezing is being subsided, so that there's better air exchange happening, and that's probably a better index as far as the success of the therapy. If you do have an adverse reaction, again, I think Lori talked about this, we stop the therapy, we monitor the patient until the symptoms resolve, notify the physician and notify the nurse. Perhaps we need to alter the drug medication, and then documentation obviously is critical. Post-therapy, not only look at objective things like where our heart rate ended up at, where our breath sounds, where's our respiratory rate, but also subjectively how they feel. Have them cough. If there's sputum production, evaluate that for color and consistency and all that kind of stuff. And then do our assessment. Did the therapy do benefit to the patient? And if so, or if not, do we need to change something? And if so, document as such. And then just all the other things as far as closure, cleaning up the area, making sure the patient's back in their safe position, their bed is where they desire it to be, ask any closing questions, and then obviously the other stuff as far as wash your hands and documentation. and be prepared to give a report to the next shift. So attending physicians admitted and contacted. The patients being admitted, they've written an order for Atrovent, Asmacort, and Intol, two puffs of each, Q4. As far as the evaluation of that order, well, first of all, Intol is no longer available. Albuterol and Atrovent, we know, come as a combination, so we can use Dulineb if that was the instance. Asmacort, we know, is an inhaled corticosteroid, so it's more of a maintenance than it is as far as a therapy at this point in time. So this will be performance evaluation number 7, which will be the first one. We'll do high flow next week, I think, and then we have a series of them coming up where there's like one every other day. So I'll give you guys some chance to practice. Patients do have the ability in some institutions to allow for self-administered therapy. If patients on therapy at home and they're in the hospital for a non-pulmonary reason, they're in for knee surgery, they still need the therapy, but it isn't something necessarily that the therapist has to sit and hold their hand at the bedside. Want to make sure the patient understands how the operation of the equipment and the electrical safety of the bedside nebulizer, what their medications are, what the treatment process is. This is where we would use a small compressor to deliver the medications. They would have their medication at bedside or at the nursing station, and the nurse would dispense it to the patient. Written instructions, and then daily we would at least daily we would go in and drop off more medications, but also do a primary assessment of the patient, and when it's necessary, they could be discontinued if the patient's obviously discharged or something along that line. I used to work with a pulmonologist who would order therapy on a stable pulmonary patient, and we asked him, why are you ordering QID therapy on this guy? He doesn't really need the therapy. He's stable. Well, I just want somebody who understands cardiopulmonary function to go in and be assessing him. He didn't trust the nursing staff to be able to properly assess his pulmonary patients, and he knew we would. I said, okay, can we at least make it PRN then, so we could just go in? We'll go up there, a couple times a shift, but he's funny. So again, they're going to, if they're using a small volume nebulizer, like we talked about, could also be that they're just using a meter dose inhaler also. Speaking of which, let's move on into the meter dose inhaler. I know Lori's covered a little bit about this as far as what the design of the internal component is, how that when an actuator seat moves as we compress it, it releases the medication through the nozzle and allows for inhalation to occur. So these are the requirements of who can do an MDI. And again, that's part of the problem, is they need to know how to follow directions. They need to be alert. They have to be able to take a slow breath to a maximal amount and hold their breath. And they have to do the return demonstration in the process. This is probably a little bit dated because HFAs have not been on the market for a long time. When the conversion went between the HFA, albuterol, Proventil or whatever, to the new, when they went from the CFC to the HFA, patients complained because they didn't feel they were getting the same effect. Well, part of it was, as you see the CFC on the right, the spray that would come out was much more forceful, so it basically was impacting on the back of the patient's throat. When we went to the HFA, the plume is a little bit different shaped, and patients didn't feel they were getting anything coming out because they didn't feel that characteristic impaction. Well, the problem was the impaction wasn't going to your lungs anyways, so this is probably a far more effective way to end up doing it. In both cases, probably a solution would have been to use some sort of a spacer, so those larger particles can be rained out. We don't have that problem. This is just talking about, again, about that size of that plume using high-speed photography. Lots of different spacers that you can end up having. Something as sophisticated as a toilet paper roll. I like that. When we get to mechanical ventilation next fall, we'll talk about proper placement of the nebulizer, and this is huge debate, although there's been very good science to be specific where we should place that within the ventilatory circuit and what kind of spacer we have. You can see the one on the left, letter A there. It's a spacer that actually collapses down and then expands for when you need to give the therapy, collapses back down again. Kind of a nice sophisticated mechanism. We know that a holding chamber is similar to a spacer, but again, it has a one-way valve, not something we would be able to use on a mechanical ventilated patient. But patients with small tidal volumes can actually take multiple breaths from that same actuation of the nebula of the MDI. Lots of different brands. I don't care that you know names. Whenever you come up with a spacer or a DPI, I don't know if Lori talked about it, but you're going to read the directions because every one of them is different. But we do know that they do improve deposition, and they're great for patients that have either poor hand-eye coordination or have very shallow tidal volumes. As it just talked about, reduces the oropharyngeal deposition. We can deliver a larger dose when we're using a spacer or a holding chamber. There's this thing called a Freon effect where the cold from the Freon actually can stimulate the patient to not continue the breath. They actually stop the breath that they're breathing in, and definitely important with steroids. You get a better particle size as well as you don't have the big issue with thrush. There are some MDI, DPI trainers, and we'll have these when we go through the PE on these two. That you'll actually be able to evaluate whether a patient's inspiratory flow rate is appropriate for that purpose. Take a look at the PE itself, but basically the same kind of a thing. Looking at the scene survey, looking at our primary survey, looking at our critical life functions, same as the small volume nebulizer. You want to go through the patient's chart for the same exact reasons as we talked about. Same process of going through an introduction and an explanation, doing a interview of the patient and getting some ideas as far as subjectively and objectively where they're at. This is basically the same slides, but now we're looking at that right hand arm of the algorithm. Getting our supplies, again, same kind of stuff. Assess the patient's ability to use the MDI or whether or not we need a spacer or a holding chamber. Shaking the canister to distribute the medication. Making sure that there's no obstruction, so if it's one where you have to take a cap off and put the thing together, you want to make sure that there's not anything that could potentially be there to be inhaled. If it hasn't been used in the last couple days or within the last, or if it's a new inhaler, do a couple priming doses. Have the patient open their mouth wide, hold upright, place 2 fingers away from their open mouth, fully exhale, and have them inspire. When they begin the inspiration is when they begin to actuate it. They inspire to total lung capacity and hold their breath, and they wait at least a minute, some say 30 seconds, between actuations if there's multiple dosing being there, and then rinsing them out if they're delivering steroids. Recap and store. Just reading a study that was released in Chest. It was talking about something like 70% of patients who are using MDIs are missing at least one of those steps and about 40%, 3 steps were not there. One of the biggest was the shaking of the canister, patients not knowing that. Not surprisingly, when the actuation of the MDI in coordination with their breath, it was actuate, take a breath in, and that's obviously defeating the purpose. Breath hold was missing in a lot of them, and the duration of time between, was just get a puff, wait 10 seconds, get another puff, and that's obviously not the proper process. So despite our training, it's still, it takes probably 3 training sessions till the patient finally gets to the point where they're getting 90% of the steps correctly, which is kind of sad. And have any of you been prescribed an inhaler? Did you get great explanations from, no. You get nothing. You get the package insert, which is typically not correct, so scary. Again, monitoring the patient, we talked about same thing for the MDI as there was for the SVN, before, during, and after. Doing, again, patient education, optimal time. Looking at the subjective response, and again, specifically if you're using peak flows or some other mechanism of pre and post. Subjective relief. Documentation. When to change canisters. We know that there's a maximum number of puffs that they can have, and it usually says right on the canister how many you can end up using, and that includes priming doses. The patient can keep a diary of how many they check. Good luck with that. And there are some commercial devices that count the number of actuations. More and more we're starting to see manufacturers kind of tie these into the design in some process. We used to recommend doing float testing, and I think Lori might have talked about that. That's been eliminated because it can cause some damage to the unit itself. And even though they may still produce a mist, when you've reached the maximum number of doses, they need to be changed out because there's very little medication in those end ones. Here's an example of the counters that you have. They'll track the number of doses or number of actuations you have. And again, they can come in a multiple of designs. Here's another one. And this is one where actually highly sophisticated computer program that's going to track them. Really? Respimat is a new inhalation spray device for the drug Combivent. It also has this technology is also used in other medications, but we're starting to see more and more of it in the area. Poor old Uncle Louie cut down in his prime. I want to stop there. You guys don't care. I know. Questions?